Hello, I'm Dr. Dax Kurbegov, Vice President, Physician-in-Chief at Sarah Cannon. I have the pleasure of speaking to you on a really interesting subject, one that simultaneously generates tremendous excitement and at the same time a fair bit of controversy. And that is really on the subject of multi-cancer early detection testing. Ready or not is the theme of today's discussion, and ready or not has dual meanings here. Ready or not is the testing platform, is the technology ready for widespread utilization? And ready or not, you as primary care physicians, as oncologists, as subspecialists, um, whatever your opinion is, certainly we're seeing commercial uptake, and you're likely to see patients in the not too distant future who have an MCED result that requires some action on your part. So our goal today is not to definitively resolve those questions. I can't do that in the allotted time, but really to share with you some of the foundations, give you a good basis for having conversations, continuing your own investigation, and certainly understanding the lay of the land when it comes to supporting a patient who has chosen to pursue a multi-cancer early detection test, particularly patients with a positive result. So we'll really start by laying a good foundation, and the timing of this discussion, I think, is excellent. While we are aspirational in our capacity to detect many cancers with a single test, we've been doing single cancer screening for quite some time. And just so that we don't all become complacent, it wasn't that long ago, fall of 2023, where meta-analysis was published and subsequently a number of media outlets covered that meta-analysis, perhaps with the wrong messaging, with messaging that cancer screening doesn't achieve a longevity benefit. And of course, I think you all know, and I'll reaffirm here, that many of those interpretations were misplaced, that looking at a single cancer screening paradigm is unlikely to, by itself, change longevity across a population. That the better question, the more important question that has been asked traditionally of single cancer screening paradigms is whether it impacts cancer-related mortality for that cancer which is screened for. So just so that we know, there's still questions being asked of even traditional cancer screening technologies. The why is important, and though we all know it, it bears just a moment's reflection on the why, and that is really that cancer outcomes remain suboptimal for many of our patients, and that the cost, whether measured in the direct cost of care, whether measured in the total economic burden seen here, or whether measured by the most human of all metrics, years of life lost, the toll of cancer on our American society remains substantial. And while we've made tremendous progress in the therapeutic domain, and I have the privilege of working alongside tremendous investigators who have contributed to many new important therapies in the treatment of cancer patients, our best strategy remains one of prevention and early detection. And early detection historically is driven through the utilization of a single cancer screening paradigm. You see that reflected here. I make, again, the argument that this is woefully inadequate in terms of reducing the burden, not to say that each individual single cancer screening paradigm isn't important. They are, absolutely. We historically screened for breast, colorectal, and cervical cancer in this country. And while the evidence base is very strong for lung cancer screening and its impact, we really underperform as a society in being able to bring those individuals, those eligible for lung cancer screening, into the healthcare community, have their screening, and then act appropriately. So with that realization, and with the recognition that that means that the vast majority, 70% of incident cancers, have no screening paradigm, it really underscores the importance of developing new strategies, new modalities by which we can identify a broader range of cancers, and obviously preferably identify those cancers when they're early and amenable to curative intent therapy. And you see that emphasized here. I think, again, this is very familiar to many of you. As a general rule, for all cancers on the left and for specifically lung cancer on the right, we understand that identifying disease at earlier stages, when localized, generally correlates with a better long-term outcome. And certainly, once cancer is advanced, you know that while we can treat patients longer, ensure better quality of life with the tools at our disposal today than compared to a decade or 20 years ago, we don't realize the ultimate outcome, which is cure with much greater regularity. And so that's the why, and shouldn't be a surprise to anybody. I want to take a few minutes and talk about the history of multi-cancer early detection development. And I think this is a fascinating story. If you're in a group and you want to pull out some trivia or look like the smart one, just ask your fellows, your peers, what are the origins of multi-cancer early detection blood-based testing, and surprise them with the origin is really grounded in our experience with non-invasive prenatal testing. And we don't have time to dive into that today, but really the story harkens back to reports beginning in 2013 or thereabouts of discordance between the findings of NIPT and ultimate fetal karyotype. That is, the blood-based testing demonstrated what was certainly suggestive of an adverse karyotype, and yet the fetus looked normal, developed normally, ultimately was born normal. And then the observation that those women were diagnosed with cancers shortly thereafter. And that's not the only story, but it was really our first hint that within the peripheral blood were the clues, in particular here cell-free DNA, that might suggest an ability to detect cancers that were otherwise clinically not apparent at the time. And so as we move from the that's super interesting to the how did we get here, the recipe or formula is really quite consistent. It's the identification of potential clues from the genome or the epigenome, so-called methylation, the proteome or the metabolome, all of these different dimensions that are potentially clues or generate signals that may be associated distinctly or differentially for cancers. The ability for our current technologies to literally find that needle in the haystack in the peripheral blood, gather all of those data points, literally on many occasions, thousands of distinct data points, put them through machine learning algorithms that then help to ultimately define a classifier that can discriminate in asymptomatic individuals, those with a potential cancer diagnosis versus those without cancer diagnosis. And I always take this moment to remind myself and remind the audience that this is not genetic testing, right? What we're looking for in multi-cancer early detection is whether or not an individual has an active cancer at the moment of testing, in contrast to our high-risk programs where we're looking for markers, genes of lifetime cancer risk. And very important and sometimes challenging to make that distinction for our patients who tend to conflate the two. But let's dive into the data just a little bit. And one of the earliest studies presented is shown here. This was a multi-analyte assay that looked at both genomic signals and proteomic signals. Again, used that machine classifier. And you can see here in the panels to the right, really interesting data. And there are a couple of themes that you'll see highlighted throughout my talk. And one is these blood-based tests have the capacity to detect a significant range of cancers. They're not one cancer screening test. They're looking for signals that are shared across a range of cancers. Important notes here. One is that while early cancers are detected traditionally and pretty consistently, these assays perform better in detecting later stage cancers. And the other that I would highlight here is that the ability to detect cancers changes by cancer type, presumably because the propensity of different cancers to shed these clues, DNA, et cetera, varies from cancer to cancer. And so, one of the questions that comes up is that's great, that's profound. We can find a range of cancers with a simple blood test. We should be doing that for everybody everywhere. One of the questions that comes up consistently is that of clinical utility. That is, just because we have an ability to find a cancer, is that synonymous with we can improve outcomes from cancer? And that's really one of the critical ongoing subjects of research. We have very limited data in this space. I want to be very transparent about that. This report from ASCO a year ago, I think, is interesting in and of itself. It is not conclusive, but this showed that in a population of individuals with cancers detected by one of these platforms, that outcomes actually look pretty encouraging. That those who were found at earlier stages have had similar outcomes, at least with 4.5 years of follow-up, to individuals that you would find identified with these cancers by any other means. So encouraging, but not conclusive. And this is something we need to build on, is the demonstration that cancers detected by this modality are not somehow distinct or more adverse or less amenable to curative intent therapy and outcomes than cancers detected by other means. I want to hover for a moment on this issue of methylation. Methylation, again, is the epigenome. It's the turning on and off of genes. And methylation patterns are inherently tend to be tissue specific. And that creates an opportunity with methylation-based assays, or at least assays that include a methylation component, in that because these tend to be tissue specific, methylation-based strategies offer the additional benefit of a putative tumor of origin site or prediction. And that will become important in our discussion in just a moment. More recent data and publication here shown looking at a blood-based assay across a population of individuals with known cancer. And you can see here, there's too much to go into in great detail, but let me call out just a couple of pieces. First, overall sensitivity for cancer was about 50%. I'd also draw your attention to specificity in the upper left panel. Very high, 99.5%. So cancer identification that comes with very few miscalls in the population of individuals that have no cancer. Again, as I alluded to earlier, you can see in the bottom left here, sensitivity varies quite a bit across a range of cancers. But take a note that some of the more common, what we consider high mortality cancers, reasonable performance in terms of blood-based detection strategies. And more detail in the panel to the right, where you can look at cancer type. And again, as a general rule, the ability to detect a signal for these cancers increases with advanced cancer. That's probably not a surprise, right? Just based on degree of cancer burden and propensity to shed. But still, with even for early stage, reasonable performance across a number of different cancer types. So let's start looking now, more prospectively. The Pathfinder 2 study was reported at ESMO last year in 2022 by Deborah Schrag. Interesting study. Eligibility included patients or participants over the age of 50. Two cohorts, those with no additional risk factors for cancer, so just age was their dominant risk factor, and those who had additional risk factors beyond age. Very straightforward design, blood-based test ordered. All of these individuals were not suspected of having cancer at the time. Health data was collected. The blood sample was analyzed, and one of two things happened. Either they had a cancer signal detected that precipitated a diagnostic odyssey, or they had no cancer signal detected. And those patients need to be, and this is my opportunity to remind you, these patients always need to be reminded that standard of care screening is not obviated by a negative MCED result. That is, it is important to continue standard of care screening. They're not intended to replace one another. And again, don't have time to go into all of the facets of this very interesting study, but want to highlight a few pieces for you. Specificity remained very high at 99.5%. Positive predictive value was very interesting. We'll talk about this in comparison to other screening modalities in just a moment, but a 43.1% positive predictive value. Also want to highlight, which you see here at the bottom, was that the test also generates a putative tumor of origin site, typically either no prediction or one tumor site or up to two tumor sites predicted. That's how you get to first and second predicted origin. And the demonstration here in this study that in almost 90% of cases, the cancer identified was either the first or second predicted origin. And I think that's important for us as clinicians who are going to be managing patients who have these tests, because it allows us with some confidence to prioritize our workup or our evaluation based on that predicted site of origin. So let's get real for just a moment. Let's do some real math, some real numbers based on that data. The first is to say, if you test 100 patients, you're likely to find one with a cancer signal detected. So this is not going to be a frequent event within a primary care clinic. Most of the patients, 99 out of 100, will come back no cancer detected. They will feel, or no cancer signal detected. They will feel encouraged. They need to be reminded to maintain their usual standard of care cancer screenings. One will come back with a cancer signal detected. Let me change the math now just to make it easier. Let's go to 200 patients tested, 198 no cancer signal detected, 2 likely to have a cancer signal detected. Of the 2, 1 is likely to have a false positive. The individual that actually had cancer, especially in the setting where that cancer is identified to be early stage, is likely to be very grateful. There's an opportunity to offer curative intent therapy. And the individual that is likely to cause the most anxiety for the doctor and obviously for the patient is that individual who has a cancer signal detected, but then has an appropriate diagnostic workup, and we can't find the cancer. What to do with that population is an anxiety point for clinicians who are entertaining the use of multi-cancer early detection. Again, this study is not definitive, but is encouraging, looking at a small population of individuals who had a quote false positive signal, and that's how we would define an individual with a cancer signal with a negative diagnostic workup. This study very briefly showed that the vast majority of those individuals with a follow-up of almost 4.5 years remained cancer-free, and that the cancers that were detected years later, not months later. And so the conclusion of this study was that it's safe to return to routine care after an appropriate initial evaluation. But again, I think this is an area where much more research is required. So in the last couple of minutes, I want to highlight some practical considerations as you think about the application, the potential application within your clinical world. And the first is really just to demonstrate performance characteristics of the current multi-cancer early screening tests that are either commercially available or in development. And this is a good reminder that sensitivity varies quite a bit. Specificity is consistently excellent across this modality with a very, very low positive rate. So again, the identification of cancer is coming at the expense of relatively few false positives. And just a sobering reminder to me that the positive predictive value for cancer actually compares quite favorably when we compare this to historical single modality screening tests. And so, multi-cancer early detection may have a place in our arsenal for cancer screening when it complements existing modalities, demonstrates the capacity to detect lethal unscreened for cancers, is able to guide us in the diagnostic workup, and particularly here where we have a very high specificity, so relatively few false positives, meaning that we're minimizing unnecessary workups and interventions. So where do I believe that there is emerging data to support the potential utilization of such testing? Clearly, cancer is an age-based risk. So in individuals over the age of 50 who are at inherently higher risk, as we all know, screening tests perform better as cancer incidence increases. So those over the age of 50 is where most of the research currently resides. There's emerging data in populations of younger individuals who may have additional risk factors, including prior cancer history. And certainly the portfolio of smoking-related cancers becomes an interesting population to look at. Intermediate evidence, as you see highlighted here, for a slightly younger, distinct subset of individuals with perhaps elevated cancer risk for additional reasons. And then on the far right here, areas where there's a good scientific rationale, but more research is really necessary to understand the type of testing, the utility of testing, the frequency of testing. And so, just again, I'm excited about this line of inquiry and the potential impact, but I also want to be realistic. There are significant issues that remain. Currently, testing is not covered by insurance. That creates an access barrier. And this testing has the potential to remediate current disparities, but given the cost, lack of widespread coverage, it may magnify equity issues in the near term. The issue of false positives we've already discussed. I think there's quite a bit of education in making our primary care communities comfortable with the testing and speaking to the testing to a patient population. And we've already hinted, there's real debate today around clinical utility. Clearly, these tests have the capacity to detect a range of cancers, including cancers at early stages. If we interpret that as likely to confer better outcomes, then you're likely an early adopter. If, on the other hand, and I think there's good reason to believe that stage migration may be a good surrogate for some cancers, but not all cancers, if the level of evidence is mortality related from individual cancers, or other measures of clinical utility, well, those studies are still very much in progress and in development. So you may be waiting a little bit longer before adopting. Regardless, I think it's important for you to know this topic because there are individuals who are actively pursuing this as part of a health maintenance, health wellness plan. And so understanding the testing, understanding how to react to the testing, certainly understanding that anybody that comes through your clinic with a positive signal needs to be taken very seriously and needs to be guided through an appropriate workup is absolutely critical. So these are my conclusions. I think the evidence base supports that such platforms can be safely implemented for adults at increased risk. There is variable sensitivity across tumor types, but overall very high specificity. Methylation-based testing is interesting in that we've demonstrated a fairly highly accurate prediction of tumor of origin locations. And so clearly it is feasible to detect cancers early with blood-based testing. And yet, here's where so much more work needs to be done. We have yet to show mortality benefit in these studies. And ultimately, the goal of all early detection strategies is around mortality benefit. I think the question becomes, are there surrogates for mortality so that we can begin to introduce these tests without having to wait another decade plus, which is generally the time frame for screening-based mortality results. Some of the cohorts have had limited diversity, and I'm encouraged that there are very specific efforts in current and ongoing and planned studies to increase diversity. More work to be done to fully understand the nature of false positive results and how we should be guiding those patients over the long term. And then as we see an increased influx of other risk stratification strategies, how do we incorporate or how do we leverage blood-based multi-cancer early detection in that context? And then, of course, the most potent barrier for the near term is cost. As these tests become available without insurance coverage, there's likely to be a very significant barrier and limitation of who's able to afford such testing, and that has the risk of magnifying disparities. And so with this, with those comments, I hope that I've given you a flavor, some background, some context, some foundations around the data that has been presented and the data that is being generated. Again, these tests are the subject of ongoing research, although some have become commercially available. I would encourage you to reach out to me, to reach out to your peers, but we collectively as a community should be actively pursuing knowledge in this space so that we can guide and support our patients who are electing such screening paradigms. With that, I'll offer you my thanks for your attention today. I hope what I've shared is interesting and thought-provoking, and wish you all the best in the continuation of your practices. Thank you and have a great day.